Welcome everyone, and thank you for being here today. I'm excited to introduce our presentation titled Oxygen Transport and Hemoglobin Dynamics in Health and Disease. On this first slide, you'll see the main title and a subtitle that highlights our focus on understanding oxygen equilibrium, delivery, and hemoglobin abnormalities. Over the course of this presentation, we'll explore how oxygen is transported in the body, the role of hemoglobin, and what happens when these processes are disrupted in various health conditions. Let's get started and delve into these fascinating topics together. Let's take a closer look at the oxyhemoglobin dissociation curve. This curve is a vital tool because it shows us the relationship between the partial pressure of oxygen in the plasma, or PO2, and the percentage of hemoglobin saturation, or SO2. Essentially, it helps us understand how readily hemoglobin picks up oxygen in the lungs and releases it in the tissues. This relationship is crucial for assessing how effectively oxygen is being delivered throughout the body. Now, understanding oxygen equilibrium and transport is fundamental. It explains how oxygen moves from the alveoli into the blood, binds to hemoglobin, and is then carried to tissues that need it. By grasping these concepts, we can better appreciate how normal physiology supports tissue health and how disruptions in this process can lead to disease. So, in this part of the presentation, we're focusing on how oxygen binds to hemoglobin, how that binding changes under different conditions, and why this balance is so important for maintaining proper oxygen delivery in both health and disease. Let's take a closer look at what this slide is showing us about oxygen content in the blood. The curve here highlights oxygen content, measured in milliliters per deciliter, and it helps us understand how oxygen binds to hemoglobin as oxygen pressure varies. Now, this is a key point. This curve isn't just a straight line. It's nonlinear and has a sigmoid shape. That means the relationship between oxygen pressure in the plasma, which we call PO2, and how saturated hemoglobin is with oxygen, or SO2, is more dynamic than a simple linear relationship. Understanding this sigmoid shape is crucial because it reflects how hemoglobin binds oxygen more readily at certain pressures and releases it when needed. So, when PO2 is high, hemoglobin is almost fully saturated, but as PO2 drops, especially in tissues, oxygen release ramps up efficiently. This brings us to the significance of plasma PO2. It plays a critical role in determining how much oxygen hemoglobin can carry. The curve shows us clearly that small changes in oxygen pressure can lead to significant shifts in oxygen saturation, which is essential for understanding how oxygen delivery adapts during different physiological states or in disease. In essence, this curve explains the dynamic and efficient way our blood transports oxygen, balancing loading in the lungs and unloading in tissues, ensuring our cells get the oxygen they need to function properly. Let's take a closer look at how oxygen loading and unloading work in the body. The curve's steep portion is really important because it allows for rapid changes in oxygen exchange. This means that small increases or decreases in the partial pressure of oxygen, or PO2, can lead to quick loading or unloading of oxygen from hemoglobin. It's a highly efficient system, especially in situations where the body needs to adapt quickly. Now, if we look at the flat part of the curve, it shows us that even large changes in PO2 result in minimal changes in oxygen loading or unloading. This stability is crucial because it ensures that oxygen delivery remains consistent despite fluctuations in oxygen levels. Finally, the overall shape of this curve is key to its function. It allows for efficient oxygen uptake in the lungs, where PO2 is high, and effective delivery to tissues, even when oxygen levels are lower. This design helps the body maintain proper oxygenation under different physiological conditions, highlighting the importance of hemoglobin's dynamic behavior. Now, let's take a closer look at how oxygen transport works in relation to partial pressure, or PO2, and hemoglobin saturation. Between PO2 levels of 20 to 60 mHg, we see what's called the steep portion of the curve. This means that small changes in PO2 here actually cause large shifts in hemoglobin saturation, or SO2, and the amount of oxygen carried. This is really important because it shows how efficiently hemoglobin can load or unload oxygen in those critical ranges. On the other hand, when PO2 rises between 60 and 100 mHg, we enter the flat portion of the curve. Here, even large increases or decreases in PO2 lead to only minor changes in SO2 and oxygen content. This is significant because it indicates that under normal arterial oxygen levels, hemoglobin is almost fully saturated, and not much oxygen is released with small fluctuations. Understanding this relationship between PO2 and SO2 helps us appreciate how our body adapts oxygen delivery during different physiological states. The steep part of the curve is where oxygen unloading is most sensitive to changes, such as in tissues requiring more oxygen. Meanwhile, the flat part ensures that at normal lung oxygen levels, hemoglobin remains saturated, providing a reliable oxygen supply. This dynamic is essential for maintaining proper oxygenation in health and understanding how disease might alter these processes. Today, we'll focus on P50 and how it relates to hemoglobin's affinity for oxygen. P50 is defined as the partial pressure of oxygen, or PO2, at which hemoglobin is 50% saturated with oxygen. Essentially, it's a useful measure of how tightly hemoglobin binds to oxygen. When P50 increases, it indicates that hemoglobin has a decreased affinity for oxygen. This means hemoglobin releases oxygen more easily to the tissues, which can be beneficial in certain physiological or pathological conditions. Conversely, a decreased P50 reflects a higher affinity, so hemoglobin holds onto oxygen more tightly, making it harder to unload oxygen where it's needed. Understanding these changes is crucial because shifts in P50 can significantly impact oxygen delivery throughout the body. For example, in some diseases, an increased P50 can help tissues receive more oxygen, while in others, a decreased P50 might impair oxygen unloading. Throughout this presentation, keeping these concepts in mind will help us appreciate how hemoglobin dynamics influence health and disease. Let's talk about the shifts in the oxyhemoglobin dissociation curve and what causes them. When CO2 levels, acidity, 23 dpg, exercise, or temperature increase, we see a rightward shift, which is also called a higher P50. This means hemoglobin's affinity for oxygen decreases, making it easier for oxygen to be released to the plasma and tissues. This is known as the Bower effect, and it's crucial during conditions where tissues need more oxygen. On the other hand, when CO2, acidity, 23 dpg, exercise, or temperature decrease, we observe a leftward shift or a lower P50. In this case, hemoglobin's affinity for oxygen increases, which reduces oxygen release to tissues. Understanding these shifts helps us grasp how the body adapts to different physiological states and maintains oxygen delivery efficiently. These concepts tie into the overall theme of oxygen transport dynamics in health and disease, highlighting how flexible and responsive our hemoglobin is to varying conditions. Let's take a closer look at the key components of oxygen delivery. As we've discussed earlier, oxygen delivery depends on factors like PaO2, SaO2, and hemoglobin concentration. However, an often overlooked but equally critical element is cardiac output. Cardiac output essentially represents how much blood the heart pumps per minute. It plays a vital role in ensuring that oxygen-rich blood reaches all tissues effectively. No matter how well oxygen is loaded onto hemoglobin, if blood flow isn't adequate, tissues won't receive enough oxygen. Now let's consider oxygen delivery to the tissues. Even if blood is well oxygenated, if blood flow is impaired, say, due to a decrease in cardiac output, oxygen delivery can be compromised. This highlights the importance of blood flow in maintaining tissue oxygenation. So, what factors influence how well oxygen gets delivered? The main ones include hemoglobin concentration, since hemoglobin carries oxygen, arterial oxygen saturation, which indicates the percentage of hemoglobin saturated with oxygen, the partial pressure of oxygen in arterial blood, or PaO2, reflecting how much oxygen is dissolved in plasma, and, as we've emphasized, cardiac output. All these factors work together to meet the body's oxygen demands. let's take a closer look at how our body manages oxygen delivery and consumption. The cardiopulmonary system typically supplies around 1,000 ml of oxygen every minute, which we refer to as DO2. This amount is crucial because it ensures that our tissues receive enough oxygen to meet their metabolic needs. At rest, tissues generally consume about 250 ml of that oxygen each minute, known as VO2. Maintaining this balance between delivery and consumption is vital for proper tissue oxygenation and overall health. Understanding these dynamics helps us appreciate how the body adapts in different conditions, whether during rest or activity, to keep everything functioning smoothly within our overall oxygen transport system. So this slide raises an important question. How does our body adjust oxygen delivery to meet the increased demands of active muscles? When we exercise, our muscles need more oxygen to keep working efficiently. This demand doesn't just happen randomly. Our body responds through a series of physiological adaptations. During exercise, oxygen demand in the muscles jumps significantly, prompting various mechanisms to kick in. These effects on oxygen demand trigger adjustments in how oxygen is transported and delivered. Understanding these adaptive processes helps us see how our body maintains optimal function during physical activity, ensuring that our muscles get the oxygen they need to perform and recover effectively. This connection is crucial to grasping the broader picture of oxygen transport dynamics in both health and disease. Let's take a closer look at the oxygen extraction ratio, which is a key concept in understanding how our tissues utilize oxygen. Essentially, this ratio tells us the proportion of oxygen that tissues actually consume relative to the amount delivered through the blood. Now, under normal circumstances, tissues extract about 25% of the oxygen carried in arterial blood. This means that the oxygen extraction ratio, or O2-ER, is approximately 0.25. It's a useful measure because it helps us gauge how efficiently tissues are using oxygen. The significance of this ratio becomes even clearer when we consider different physiological and pathological states. For example, if tissues need more oxygen, say during exercise, they can increase extraction, raising the ratio. Conversely, in certain disease conditions, this ratio might change, indicating altered oxygen utilization or delivery. Overall, understanding the oxygen extraction ratio gives us valuable insight into tissue oxygenation and helps us interpret how well the body is meeting its metabolic demands under various conditions. Now, let's talk about what happens when oxygen delivery drops below a certain critical point, which we call due to crit. When this threshold is crossed, tissues can no longer get enough oxygen, and as a result, they become hypoxic. This lack of oxygen triggers the body to produce lactic acid, leading to a shift from the normal aerobic metabolism to anaerobic pathways. This shift is a clear sign that tissues are under stress and not receiving adequate oxygen. In critically ill patients, this situation is particularly concerning because their oxygen delivery systems might fail to meet the tissue demands. When oxygen delivery drops to or below due to crit, it's a red flag that tissue oxygenation is compromised. Understanding and recognizing due to crit is crucial in clinical practice. It helps us prevent tissue damage by intervening early and guiding our treatment strategies effectively. Essentially, being aware of this threshold allows us to act before irreversible damage occurs, ensuring better patient outcomes. Blood transfusions are quite common in the United States, with around 15 million units used annually. They play a crucial role in managing various blood-related conditions, especially anemia. Now, anemia is generally defined as having a hemoglobin level below 13 grams per deciliter in men and below 12 grams per deciliter in women. This threshold helps us identify when a patient might need intervention. Clinical guidelines suggest that for most patients, transfusions are recommended when hemoglobin drops to around 7 to 8 grams per deciliter. This range is considered safe and effective for restoring adequate oxygen transport without unnecessary transfusions. So, understanding these thresholds is key because they guide us in making evidence-based decisions about when to transfuse, balancing the benefits of increasing oxygen carrying capacity against potential risks. All of this ties into our broader discussion of hemoglobin dynamics and how they impact health and disease management. Let's talk about the mechanism behind cyanosis. When hemoglobin releases oxygen, it transforms into deoxyhemoglobin. This change in state causes it to adopt a deeper purple color, which is what we see as cyanosis. Essentially, it's the visual cue that there's a significant amount of deoxygenated hemoglobin in the blood. Now, defining cyanosis itself. It's the bluish discoloration you notice on the skin, nail beds, lips, and mucous membranes. This occurs when the level of deoxyhemoglobin in the blood reaches or exceeds about 5 grams per deciliter. That increase in deoxyhemoglobin is what causes that characteristic bluish hue. Looking at cyanosis from a clinical perspective, it's often observed in patients who are severely hypoxic. When oxygen levels drop significantly, the body can't oxygenate the blood properly, leading to this visible sign. Recognizing cyanosis is important because it's a clear indicator of underlying oxygenation issues, linking back to our overall focus on oxygen transport dynamics in health and disease. Now, let's discuss oxygen transport and the dynamics of hemoglobin in both health and disease. On this slide, we see that one key issue can be low venous oxygen saturation, or SvO2, even when arterial saturation, SaO2, appears normal. This situation often occurs when blood flow is reduced, leading to increased tissue oxygen extraction. In other words, the tissues are pulling more oxygen out of the blood because less blood is reaching them, which can result in a mismatch. You'll notice that this typically affects extremities such as the skin and nail beds, resulting in a condition called peripheral cyanosis. Peripheral cyanosis indicates a more subtle, or perhaps early, sign of hypoxemia, meaning low oxygen levels in the blood, mainly due to low SaO2 caused by inadequate lung oxygenation. This affects areas like the skin, nail beds, lips, tongue, and mucous membranes, which are particularly sensitive to changes in oxygen levels. In contrast, central cyanosis signifies a more pronounced hypoxemia. It occurs when SaO2 drops significantly, reflecting a more systemic problem with oxygenation, often related to lung issues. So, to sum up, understanding the difference between peripheral and central cyanosis helps us identify the severity and underlying cause of hypoxemia. This is crucial in clinical assessment and guides us in managing patients effectively. Let's talk about the impact of severe anemia on cyanosis. In cases of severe anemia, the total hemoglobin level is significantly low, which means even if there is hypoxemia, cyanosis might not be visible. This is because there's simply not enough desaturated hemoglobin to produce that characteristic bluish coloration. Now, moving on to cyanosis and severe hypoxemia, it's important to understand that cyanosis doesn't always appear when oxygen levels are dangerously low. In fact, cyanosis can sometimes be absent even in severe hypoxemia, which can be a bit counterintuitive. This brings us to the variability of cyanosis in hypoxemia. The presence or absence of cyanosis can depend on various factors, including the concentration of hemoglobin and the distribution of desaturated hemoglobin in the blood. Finally, let's consider carbon monoxide poisoning. Co-binds to hemoglobin to form carboxyhemoglobin, which is bright red. Interestingly, this form of hemoglobin doesn't produce the usual cyanotic color, so even when hypoxemia is present, cyanosis may not be observed. This is a critical point because it highlights how different types of hypoxemia can present differently, reinforcing the importance of understanding the underlying cause when assessing oxygenation and cyanosis. Today, let's discuss how carbon monoxide, or CO, interacts with hemoglobin and what that means for our health. Hemoglobin actually binds CO with about 210 times greater affinity than it does oxygen, which is quite significant. This means that when CO is present, it can easily latch onto hemoglobin and prevent oxygen from binding effectively. This high affinity drastically impacts oxygen delivery to tissues. When hemoglobin is bound to Co, the oxyhemoglobin dissociation curve shifts to the left. Essentially, this shift makes it much harder for oxygen to be released where it's needed most, leading to tissue hypoxia despite having normal or near-normal oxygen levels in the blood. This condition, where hemoglobin is bound to Co, is called carboxyhemoglobin, or HbCO. Recognizing and understanding this abnormality is crucial, especially in cases of co-poisoning. Now, regarding treatment strategies, the main goal is to displace Co from hemoglobin as quickly as possible. Administering 100% oxygen is the first step, as it helps reduce the half-life of HbCO from about 80 minutes to roughly 80 minutes. In more severe cases, hyperbaric oxygen therapy can be used. This involves breathing pure oxygen in a pressurized chamber, which accelerates the clearance of Co even further, bringing the half-life down to around 22 minutes. Overall, understanding the high affinity of Co for hemoglobin underscores the importance of prompt and effective treatment to prevent tissue damage and restore normal oxygen transport. Let's take a closer look at fetal hemoglobin, or HbF. This form of hemoglobin is present during gestation and has a higher affinity for oxygen compared to adult hemoglobin. This increased affinity is crucial because it allows the fetus to effectively extract oxygen from the mother's blood, facilitating oxygen transfer from mother to fetus. It's a key adaptation during development. Now, moving on to methemoglobin, or MET-HB. This is a form of hemoglobin where the iron is oxidized to the Fe+++ state. When iron is oxidized this way, it can no longer bind oxygen, which impairs oxygen delivery. Normally, methemoglobin makes up less than 1% of our total hemoglobin, so our bodies keep it well regulated under normal conditions. However, certain factors can cause abnormal hemoglobin forms. For instance, methemoglobin can form in response to nitrate poisoning or exposure to oxidant drugs. These are important causes because they can lead to reduced oxygen transport, which is especially critical in disease states or poisoning scenarios. Understanding these abnormal forms of hemoglobin helps us grasp how various conditions impact oxygen delivery in health and disease, reinforcing the overall importance of hemoglobin dynamics in our physiology. Let's take a closer look at what happens at the molecular level with HbS, or sickle cell hemoglobin. When oxygen levels drop, HbS tends to crystallize, and this crystallization causes the red blood cells to take on a sickle or crescent shape. This change in shape makes these cells much more fragile and prone to breaking apart. When red blood cells rupture, it leads to anemia, which is a shortage of healthy red blood cells that our body needs to carry oxygen effectively. Now, beyond hemolysis, sickled cells can also form thromboemboli, which are essentially clots that can block blood flow. These blockages can cause ischemic pain resulting from restricted blood supply, and in severe cases, they can even lead to strokes. This highlights how the abnormal shape and behavior of sickled cells contribute not just to anemia, but also to serious vascular complications. Focusing on sickle cell hemoglobin itself, it's important to understand that sickling episodes aren't constant. They tend to happen intermittently. Often, these episodes are triggered by prolonged hypoxia or low oxygen levels, which complicates disease management. Managing sickle cell disease requires careful monitoring and treatment to prevent these crises, especially since triggers like hypoxia can be unpredictable. Overall, this slide underscores how the unique properties of HbS impact the entire blood flow and oxygen delivery system, highlighting both the molecular and clinical challenges we face in managing sickle cell disease.